Hi, I'm Keith Boniface. I'm going to talk to you today about soft tissue and musculoskeletal ultrasound. The clinical areas that we use musculoskeletal and soft tissue ultrasound in the emergency department really surround soft tissue infections, soft tissue foreign bodies and removal, tendon injuries, tendinopathy, joint effusions and arthrocentesis, and fractures and reduction. And over the next 45 minutes or so, I'm going to go through all of these areas. Now, for the clinical question of soft tissue infections where you're at the bedside of a patient, they have a red extremity, and you're wondering whether there's a soft tissue infection that's just a cellulitis, or whether there's an underlying abscess that needs to be incised and drained in order to have full recovery, ultrasound is a great tool, and we'll go through some pictures of this. Ultrasound for detection of a cold abscess really began back in the 1980s in intravenous drug abusers who had groin lesions, and ultrasound was critical and still is in distinguishing between cellulitis, abscess, lymphadenitis, pseudoaneurysms, which is definitely something you don't want to incise and drain at the bedside, septic thrombophlebitis, and retained foreign bodies. So key tool for evaluating the swollen, tender, soft tissue. It's also a great tool for identifying surrounding vascular and anatomic structures that you wouldn't want to injure as you approach for an incision and drainage procedure. And it's also great to identify the best pathway to reach the pocket of purulence through an area of previous scarring, say someone who has hidradenitis suppurativa and has had multiple incisions and drainage in the past. The ultrasound technique for soft tissue ultrasound involves a linear probe. The high frequency probe is perfect for giving you a high resolution picture of the superficial tissues. The only time that I usually would end up needing to use a curvilinear or a phased array probe for deeper structures is someone where I'm worried about a deep pocket of infection. This tends to be in gluteal abscesses or in abdominal wall abscesses, especially in post-operative bariatric patients. The more gel you use, the less pressure you have to apply to get a good picture, so use lots of gel. We'll use a probe cover of some sort. It doesn't need to be sterile, but it's something that helps to prevent tissue from getting infection from spreading from the patient to the probe and then to the next patient. So you can either cover with a tegaderm or a non-sterile glove with gel both inside and out. And use multiple planes. Scan through, and orientation doesn't really matter, just scan through in multiple perpendicular planes to get a good three-dimensional picture of what you're looking at. And usually this is at a minimum of depth setting, unless you're looking at somewhere deep in adipose tissue. The normal ultrasound anatomy of the extremities has a number of different echogenicities that you'll get used to seeing. You have skin and soft tissues up at the surface. Then deep to that you have these kind of fibrillar patterned muscles, depending on whether you're looking at it in long axis or short axis, with bright fascial boundaries to it. You'll have tendons, which are even brighter, hyperechoic, cable-like fibrillar structures. You have bone, which is bright white, hyperechoic, with a dense shadow behind it because ultrasound can't penetrate that bone. And then just adjacent to the bone, you'll see this anechoic, hyaluronic cartilaginous tissue, not to be confused with fluid. Now, cellulitis, the most common soft tissue infection, on ultrasound appears to have hyperechoic skin and a diffuse increase in echogenicity of the subcutaneous tissues. And woven through these fatty lobules that are bright brightly echogenic in the subcutaneous tissues. Woven through that are these hypoechoic strands of edema fluid in a pattern that's called cobblestoning. And this is completely nonspecific. You should not see this and say, this is a cellulitis. When you see this, know that you'll see the same type of picture in cellulitis, in CHF, in patients with DVT, nephrotic syndrome, pregnancy and edema. So it's totally nonspecific. That cellulitis cobblestoning looks like this. So you, just like in a cobblestone street, you have areas of hyperechoic fatty lobules and these woven strands of black fluid that move their way through the area of fatty subcutaneous tissues. Now, it's important to know that not all black areas in soft tissue infections needs to be drained. You would be at it a long time if you were trying to drain all this fluid out, and it would not be helping the patient. So you're looking for larger accumulations of black in the setting of soft tissue infections. So this is exactly what you'd expect to see in cellulitis, or it could be in someone who has a DVT or someone who has congestive heart failure and hasn't been taking their Lasix. Now, abscesses often begin in areas of cellulitis, so you'll see this type of cobblestoning, nonspecific changes, but then in the center of that area, you'll see a hypo or anechoic center with a hyperechoic rim. And these abscesses can contain echogenic debris, can contain septations, can contain air, and just like Dr. Nachatende showed in Grand Rounds this week, you can see that fluid move with probe pressure. It looks sort of like a lava lamp. You can get this sort of swirling sign. Abscesses are also characterized by posterior acoustic enhancement. We'll get to that in a second. On Doppler, you'll see a hypervascular rim around this central area with no vascular flow. And if an abscess lies against a bone, then you should suspect osteomyelitis. Now, in the center of this tissue with cobblestoning, bright hyperechoic tissues, all of a sudden you see this anechoic area in the center, and this represents an abscess. Now, every time you see a black area, you should have the immediate instinct to put color flow on it, because before you incise and drain, you want to make sure that there's no vascular flow in there. So in this particular patient, this happens to be someone's upper extremity where an AV fistula had been placed for the purposes of dialysis. And so this person has the AV fistula deep to this large area of cellulitis superficially, and then complicated abscess with no visible flow in there. Obviously, this is not an abscess that I would drain by the bedside. This is someone that would meet their vascular surgeon to get this drained while they're in the hospital getting IV antibiotics. This is an abdominal wall postoperative abscess. You can see this amazing swirling that happens with some gentle pressure. This purulent debris just sort of moves around here. So you have this pocket that curves around and gets to here, and the peritoneal lining is over on this area here. And then you can see swirling here with some gentle pressure. You can see this to and fro movement. This is someone who had a knee surgery. This is their tibia coming up to the proximal tibia and the knee joint itself. And so this is ended up being an osteomyelitis of the tibia, as you can see, with this abscess lying directly adjacent to the bone. How about this one? Is this an abscess or not? Obviously, you're looking at this saying, I'm not going to put a needle in that. I'm not going to incise this. Is this pulsatile artery deep here? But how about this? Hypoechoic area. You can press on it, see if it swirls at all. But again, before you incise and drain, you want to make sure that there's no vascular flow in there. And as you put vascular flow on there, you can see that there's this vascular pedicle and branching vasculature inside this area, and this is a lymph node. So a lymphadenitis often accompanies areas of cellulitis, so make sure that you're not dealing with lymph nodes. Another thing to be familiar with the ultrasound appearance is necrotizing soft tissue infections. So the hallmark of necrotizing soft tissue infections is air in the subcutaneous tissues, as well as subfascial fluid or thickening that we don't actually see on these two pictures. On the left, this is the lateral thigh of a young boy who had been bitten on his leg by a dog several days back, and you see skin and soft tissues. This is fascia here, and then muscles. These are the muscle fascicles deep, and you see this air in the soft tissues here, these bright white areas with reverberation artifacts that you'll get to know from looking at bowel, from looking at the lungs either. And so what we did was just lined up the abscess with the got copious purulent discharge. So the bottom line for abscesses and soft tissue infections in ultrasound is that we know that abscesses occur in cases of simple cellulitis. We aren't, I think it's not quite certain which of these occult abscesses will just go away with antibiotics and which would present later as treatment failures. But identifying these occult abscesses and by anything that approaches a centimeter in diameter is something that I would incise and drain anywhere in that half a centimeter to a centimeter kind of range. It's clear that if you're not sure about whether there's an abscess or not, you don't need to stick needles into anything to find pus. Just use an ultrasound to identify that purulent collection. And ultrasound, if you walk into the room and you feel a fluctuant abscess, ultrasound's not very helpful unless you're not sure whether there's an abscess or not, unless you're worried about a pseudoaneurysm, or if you're planning an incision and drainage around tendons, around nerves, around vasculature, or prior incision and drainage sites. Moving on to foreign bodies. These foreign bodies that present to the emergency department tend to be found in the vast majority of cases in the hand and the feet. Now, this Anderson study is quoted all through every article about hand infections that has ever been written, and in it they say that 38% of retained foreign bodies in the hand were overlooked initially. That much quoted number seems really high, but it's out there. The problem is there's no perfect test available. Physical exam misses them, x-rays miss them, CT is in fact a terrible test, MRI is an excellent test but difficult to obtain, and if you have a metallic foreign body it can be a disaster. So we warn all patients about the possibility of foreign body being present. And foreign body removal can be really challenging. And so, when you're running back and forth to the PACS to look where this radio-opaque foreign body is, to try and get a sense of where it is in 3 dimensions, it can be very challenging. And oftentimes, after a significant period of time goes by, we cut our losses and refer patients out with a foreign body in place. It's unsatisfactory for everyone that's involved, and although it minimizes lawsuit risk, it isn't the best for the patient. Getting that foreign body out would be ideal. Now, some foreign bodies are obvious. You don't really need an ultrasound to go hunting for them. But I think it's important to note that that lawsuits happen, and foreign bodies are a leading cause of these. This is mobile law office that was set up outside of my ER as a residency, and they would just, during residency, and this lawyer on board would just say, hey, have you been injured? Are you satisfied with your care? So there are people out there just looking for your patients. Now, when you look at overall the lawsuits that happen against emergency physicians in this country, 15% of all lawsuits involve wounds, and a third of them involve retained foreign bodies, and a third of them involve missed tendon or nerve injuries. So ultrasound can be helpful. There's been a lot of literature published about foreign bodies and ultrasound, and it's of widely varying methodology and quality, and every possible permutation of how you could do the study has been done. Different types of tissues, different types of foreign bodies, different ways to introduce foreign bodies into models, different people doing the sonography. And so the sensitivity ranged from, 50% in the study where large air pockets were introduced to almost 100% sensitivity in the study with homogenized beef cubes with no internal echoes. So if you look at all these studies, I think a good reasonable number to keep in your head is 80% sensitivity. And I don't think I would keep that just in your head. I will tell people this number. People who are in the emergency department who get an ultrasound think they're having a test that's ruling out a foreign body. And I tell them explicitly that ultrasound can identify foreign bodies, but even in the best of hands, I will miss 1 out of every 5 foreign bodies. And so if you think you have a foreign body, you likely do, and follow up. Now, the technique for foreign body ultrasound, it uses the linear high-frequency vascular transducer. You set the depth to a minimum. Most of these foreign bodies are less than 2 centimeters deep. Acoustic standoff is a fancy word for something that's transparent to the ultrasound beam that allows your probe to be a little further from the patient. And radiology uses these gel pads to get the ultrasound probe a little bit off the skin. In emergency medicine, we tend to use 100 cc bags of saline with gel on either side and just use it as a standoff. And what that does is it drops the area you're looking at from being so superficial on the ultrasound image that the ultrasound beam hasn't had a chance to focus down more towards the middle of the screen where it's in the focal zone of the ultrasound, and you get better resolution. And we'll talk about a special way to make that happen that doesn't involve an acoustic standoff in a second. And my general approach is, as I scan through in multiple planes, I'll look for shadowing. And that shadowing is often the first clue that I get to a foreign body. Once I find a foreign body, I'm going to refine my image and fan back and forth and rotate my probe until I get a long axis view along the foreign body. And once I see the foreign body in long axis on the screen, I know that the ultrasound beam, the ultrasound probe is indicating the direction that the foreign body is going in. Then if I'm having troubles, I can look at the contralateral side. Practicing on normal hands and feet is a good idea. And if you have someone who has, say, they've ground some gravel into some road rash, and you're looking for foreign bodies, air sometimes gets introduced. So sometimes immersing the part in water and massaging it can minimize that air artifact. Now, this picture is from Time magazine back in the 50s. It's one of the first ultrasound machines. It's quite a picture. This sad-looking person in the bathtub probably has more degrees than I have, but some smart emergency doc took a look at this picture and said, "Why can't we do this with ultrasound in 2020?" And so this is from the group in Georgia, Mike Boniface, doing the water evaluation technique, and basically it uses the ultrasound as your coupling agent. So you don't need any gel. You just place the probe in the water and hover over the body part to drop it into the focal zone of the probe. Now, importantly, these transducers are guaranteed to be waterproof until they've been dropped, and just as importantly, all of our transducers have been dropped. So using this technique, I'll take a non-sterile glove. I'll put some gel in the palm of the glove. I'll place the probe inside the glove, and then I will put the glove in the water, but not past the cuff of the glove, in order to protect the probe and to make sure no one gets electrocuted. So this is what a foreign body looks like. This is going back and forth. This is the foot of an elderly diabetic woman who came in with a diabetic foot infection. We did all the usual things, did some labs, gave her some IV antibiotics, and planned an admission. We got an x-ray looking for gas, and found a metallic foreign body on there. And on ultrasound, this is with the probe against the sole of the foot. So this is plantar aspect shining towards the dorsal aspect. This is metatarsal head here, and you see this chunk of sewing needle that the patient had scuffed over on the carpet without even knowing that it was there because of her neuropathy. Now, this is obviously not something that we are going to get out in the emergency department. This person got admitted, got IV antibiotics, got their cellulitis treated, and then ended up getting this removed by podiatry as an inpatient. Here's another case. This is a nurse in one of the local private practices around GW who came on in saying that she had been doing some sewing work. Her phone rang, she got up to go grab it, and then as she sat down after she got her call, she sat right down on her sewing needle, which went right into her buttocks. So she's got this needle in her backside. Thankfully, it had thread sticking out of it, so she just carefully grabbed the thread and tried to pull it back out, and the thread snapped. So then she comes to see us with a sewing needle embedded in her backside. Now, we could have gotten an x-ray, multiple views, soft tissue buttocks, and then tried to plan our approach then, but it was much easier to have her just point to where it hurt, put the probe on there, find a long axis view of this foreign body, and you can see this metallic foreign body with this reverberation pattern. This is a typical picture for metal, just like on the sole of the foot, bright white with reverberations deep to it. And so once I have the long axis view of this, I can find the proximal end, the most superficial end, and make my approach. This took 1 cc of lidocaine, a 1/2 centimeter incision, forceps, and it was out in 5 minutes. This is another type of foreign body. This is someone on the fast track who had groin swelling, swore that they weren't doing drugs. My concern was for all the things that can happen in the groin of IV drug abusers. So I took a look with ultrasound, looking for an abscess, looking for lymph nodes, looking for pseudoaneurysm, and this is what I see. And you see this sort of fishhook appearance here, but what you're seeing here, this is a bright metallic area with some dense shadowing behind it, and it comes down here. What you're not seeing is the mirror image of this coming around here because it's lost in its own shadow. So this very bullet-shaped structure was a bullet. So this person forgot that they had been shot back in the 90s, and this bullet was just working its way towards the surface. So this thing is about 3 millimeters deep. We took a cc of lidocaine, made an injection there, incised the overlying skin, dissected down with blunt forceps, dissected our way around this, popped it out, put it in a urine cup, and called MPD. And they came and picked it up for the chain of custody for this 20-year-old cold case of a shooting here. And this metallic foreign body in the superficial soft tissues, thankfully, did not violate the thorax. And here's what would foreign bodies look like on ultrasound. The shadowing is what catches your eye, right? Here's the metatarsal head. This is the sole of the foot. This is someone who was walking along in flip-flops and scuffed their flip-flop over a stick, and the stick went over the flip-flop, under the foot, and into the sole of the foot. So you have this bright white reflection here, but it's not quite as bright white as the metallic foreign bodies are, and it's really the shadowing that helps you to pick this up. In this video, we see someone with their hand in a water bath. That's why the probe, where the probe is touching, there's nothing here. So this is just water that it's going through. You see some bubbles floating around in the water. And this is a local bartender who was washing some glasses, and one of the wine glasses broke, and a little fine piece of glass was stuck in their palm. This is metacarpal here. I think this is probably first phalanx going in this direction here. You can see flexor tendons right here, and you see this bright white line here with some surrounding inflammation. Okay, so this is a glass foreign body, really a millimeter or two deep. It was a matter of raising a little tiny wheel, making an incision, and getting that out. So some foreign bodies are easy to get out like this. Some are a little more complicated, and a technique that's very helpful is called Hydra dissection. So Again, once you find the foreign body, get a long axis view of that foreign body, and then with a 3 or a 5 cc syringe with lidocaine, depending on how deep you have to go, you'll basically pretend that you're putting your needle into a vessel in long axis view. You'll follow your lidocaine needle down towards the foreign body with ultrasound guidance in plane, injecting anesthetic along the way. And what that allows you to do is make a small incision afterwards, then blunt dissection down with forceps, also under ultrasound guidance, until you can bump your forceps up against the foreign body. You can feel it, and then you can rotate your forceps 90 degrees to see the jaws open and close under ultrasound guidance, and then grasp the foreign body and remove it. This is someone who got some deck pieces into their foot. This is the sole of the foot. There's metatarsal heads here. Here's the lidocaine needle coming in here. You can see the anesthetic being injected around here. So there's a Hydra dissection, dissecting this out from the surrounding tissues. As we do so, you see that it's not just one but two splinters here. So as you're getting the lidocaine, splitting these two out. And then you can make a small incision or go in through the original hole, get in there with your forceps, and as you grab through, you can grab that foreign body right here. You'll watch the foreign body move on ultrasound, and then you can pull it on out. And then afterwards, you can sweep across and ensure that you got all the foreign body. Okay? And this is what came out of that lady. Similarly, this is that person who had picked up the stick on after a storm above the flip-flop. This is the forceps grabbing onto this foreign body. You see it's much longer than you actually thought. And this also came out in two pieces. So ultrasound in foreign bodies are useful especially for those organic and plastic foreign bodies that don't show up on ultrasound. It's not perfect, and make sure you tell patients this, but it's increasing the yield of foreign bodies compared to what you're doing now without ultrasound. It's helpful to identify other anatomic structures like vasculature and tendons relative to that foreign body, and it can be invaluable in removal of both radioopaque and radiodense foreign body. For Hydra dissection, you find the long axis of that foreign body, make an incision, and remove it, or you can use Hydra dissection and inject anesthetic down to that area, down to that foreign body until your lidocaine needle bumps up against your target, and then dissect down with blunt dissection to grasp that foreign body. Okay, moving on to tendons. The Achilles, we're going to talk about Achilles, patellar, and quadriceps tendons as these big tendon injuries, and then flexor tenosynovitis, tendon lacerations, and we're going to skip rotator cuff evaluation just because of time. One thing to keep in mind as we go through is a fancy word called anisotropy, and this really is a word that just describes an artifact that occurs with artifacts, especially in tendons, but also in nerves. And it indicates the property of tendons where if your ultrasound beam is not exactly perpendicular to the axis of the tendon, then you will get a signal dropout and it will just look black. And so if you have a tendon and long axis on your screen and there's a black area to that tendon, especially if it's an area of curvature of the tendon, then heel-toe rocking of that probe is necessary to interrogate that structure in order to bend that ultrasound beam so it's perpendicular to the long axis of the tendon. And that heel-toe rocking of the probe is necessary to make sure that the dark areas and tendons that you're looking at are pathology and not just signal dropout from anisotropy. This is the patellar tendon. There's the patella. We're sliding down inferiorly, orientation marks towards the head. You can see this fibrillar pattern here going all the way down to the tibial tuberosity, and then soft tissue superficial. So this is a nice, normal, healthy, fibrillar-looking tendon being held relatively taut by the normal contraction of the quadriceps tendon. This is the tibial tuberosity. Here's the patellar tendon going on up in an abnormal patient as we keep going up. Then we're left with an area of loss of that fibrillar echoed pattern. You see some increased black areas to that tendon. And as I slide across here, you can see almost an area right here where a fragment of patella has been pulled off by the patellar tendon, causing some acoustic shadowing. Here's the patella here. Here's a gap and with hemorrhage in it. And then here's the torn end of the patellar tendon. So these patellar tendon ruptures are relatively easy to see on ultrasound. We tend to miss these in emergency medicine, not commonly, but when we do miss them, we miss them because we haven't thought about the diagnosis and haven't examined the patient. So there's no real miracle about ultrasound protecting you from missing this diagnosis. You have to think about the diagnosis to do the exam or to do the ultrasound. Okay. And this is just another view through there to that torn end here, another patient, separate individual hemorrhage in between here. Here's an Achilles tendon, normal Achilles tendon here. Oops, it's not very helpful. Here's another Achilles tendon with a little bit of anisotropy here at the calcaneus, and this nice fibrillar pattern here. And then as you slide up towards the calf, you can see this fibrillar pattern here, and then the sort of torn end to that Achilles tendon with hemorrhage. And just like as you're looking for an abscess, you can do some gentle compression. You can see some swirling there of that torn tendon and the hematoma. This is a greatly magnified picture of the palm of the hand. So this is a much smaller tendon, but this is a laceration of one of the flexor tendons of the palm, overlying one of the metacarpals. And so it's a nice way to identify these retracted, lacerated tendons. Other tendon pathology that you can see, this is flexor tenosynovitis. This is the metacarpal right here, and the flexor tendon just superficial, and you can see all this kind of swirling debris surrounding this tendon in the tendon sheath. I just want to spend the remaining time talking about musculoskeletal ultrasound, really focusing on joints for the purposes of diagnosing effusions and guiding aspiration of effusions, and we'll talk about all these joints. So the shoulder joint, those of you who were at Grand Rounds last week, you should be familiar with this posterior glenohumeral joint view. This transverse view with your linear probe just inferior to the scapular spine is a perfect view to get a window to that glenohumeral joint. It can identify for the presence of a dislocation or relocation of the glenohumeral joint, as well as identify any fluid in that joint space. Once you slide underneath that scapular spine, you'll slide laterally until it intersects with the humeral head, and you can see the glenohumeral joint. And normally, a normal alignment will show the humeral head at the same depth as the glenoid, and as the person internally and externally rotates their upper arm, you can confirm that that articulation of the glenohumeral joint is intact. If you're looking to do an arthrocentesis, I come from the medial aspect of this probe to avoid going through avoid as much of the rotator cuff tendons as possible. This is what a normal tendon normal glenohumeral joint looks like. We have the humeral head is quickly recognizable as this ball right here. And then here we have the scapula coming over. We're just inferior to the scapular spine. You see a scapular notch, and if you look carefully, you can sometimes see some vasculature there. And then it flares out to the glenohumeral joint, and you'll see a bony labrum and then a cartilaginous labrum there. And so the fact that these two are articulating nicely, you can sort of see as the person rotates their shoulder in and out, you can see that it's nicely articulating there. That is a well-located glenohumeral joint. If I was looking for the presence of a joint effusion and fluid in this joint, I would be looking in this triangle right here, knowing that there's oftentimes a little black rim of cartilage here that is normal and that parallels that humeral head. This image is same view from posterior, so this is posterior shining anterior. We have skin and soft tissues, then posterior deltoid, then infraspinatus. Remember, we're just inferior to the scapular spine, so this is the infraspinatus muscle of the rotator cuff. And then we have the glenoid right here, and the infraspinatus comes over here and then falls like a waterfall going over a cliff to catch up with a humeral head, which is way anterior. Again, probe is posterior here, shining posterior to anterior like a flashlight. So this humerus is dislocated almost 2 centimeters anterior to the glenoid here. Now, once you reduce that shoulder, you can see that normal bony labrum here. One second, we'll pause it. You see bony labrum here, cartilaginous labrum here, which doesn't show up on x-ray, and then the humeral head, all in good alignment. And as the person does a micro range of motion in and out, you can see this sliding past that glenoid. The same exact approach, posterior, just inferior to the scapular spine, slid laterally till you see the glenohumeral articulation, is the view that I use to look for shoulder effusions as well. So this is the medial aspect here, this is the glenoid right here, and then the humeral head is very easy to identify. This person is a much bigger person, and so we're using a curvilinear or a phased array probe here, but the same principles apply. And in the middle, you'll see this triangle of black. This is fluid bulging out of that glenohumeral joint. And if I were to go and do an arthrocentesis, I would come from the medial aspect here and just follow my needle till it reached that target, and you're able to aspirate that fluid. This is the case from last week's grand rounds, where you see the person's in a modified Kraus position here with their hand on their hip. This is looking at the position to look at the supraspinatus tendon of the rotator cuff, as well as the subacromial subdeltoid bursa. And I put the orientation mark towards the patient's head. I have the edge of my probe right on the acromion, and so orientation mark is towards the head. The edge of my probe is right on the acromion, and then this is down towards the elbow. So this is humeral head right here. We have supraspinatus here, the most commonly injured tendon of the rotator cuff. We have the lateral deltoid right here, and right in between we see this little bird beak of the subacromium subdeltoid bursa. And so for this person who had a painful arc, we guided the needle towards that target coming from the inferior aspect here. So the needle is coming from the inferior non-orientation mark side of the probe through the deltoid into that subacromium subdeltoid bursa, and then 1 cc of 40 milligrams of Kenalog or triamcinolone and 1 cc of 1 or 2% lidocaine, and the person felt much better within 5 minutes and for several weeks after. Moving on to the elbow. The elbow arthrocentesis that I was taught during residency involved threading the needle between the radial head, the lateral epicondyle, and the olecranon. In the center of this triangle is where the needle entered. I was taught to do this for radial head fractures to drain hemarthrosis and improve patients' range of motion and improve their rehabilitation. The thought of squeezing this needle past this radial head fracture has prevented me from doing this for a long time. And thankfully, there's a better way. So when you look at the anatomy of the humerus, posteriorly, there's this olecranon fossa here. This is a divot that is at the posterior distal upper arm, that when the arm is straightened, the olecranon moves into that area. Now, what sits in that area is the fat pad. So if this is the distal posterior humerus, right in here there's a divot, and that divot is the olecranon fossa. That's where the fat pad sits. When you have a hemarthrosis or joint fluid, that fat pad is pressed out, and it's slightly less dense than the surrounding soft tissue and muscle. And so this fat pad that you see on elbow x-rays, which is called the posterior sail sign, which is always indicative of pathology, is as a result of fluid filling up that olecranon fossa. Now, the nice thing is, with ultrasound, you can identify that olecranon fossa very easily. So with a long axis view to the posterior elbow, orientation marked towards the shoulder, you have orientation marked towards the shoulder, you have humerus that'll come down here, then there's this divot of the olecranon fossa, and then up to the elbow joint, triceps overlying and triceps tendon, and then fat pad that lays sort of beneath the surface here of the humeral line. On ultrasound, you just see this bowl of the olecranon fossa filled with a fat pad and no fluid. On transverse view, you see that same bowl of the olecranon fossa with a fat pad sitting in there. And then as you fan back and forth or slide up and down, you can see the fat pad occupying that entire olecranon fossa space. Now, when someone has fluid, from whatever reason, these patients had connective tissue disease and concern for septic joints. You see this olecranon fossa here with black fluid through here, and this fat pad is compressed and pushed out of that olecranon fossa. And so this is something that you would see as a posterior sail sign on a lateral elbow x-ray. Same thing here, fat pad pushed out on that lateral elbow x-ray by this fluid occupying the olecranon fossa. A hemarthrosis looks somewhat different. Oftentimes, as you slide down distally, you'll see this more echogenic fluid. Sometimes this is as a result of fat from the bone marrow coming into that joint space, and so you get this hemarthrosis here, again compressing that fat pad out of the olecranon fossa. In transverse view, you see this anechoic fluid in the bowl of the olecranon fossa. If you're going to do an arthrocentesis, it's much simpler to do it from this posterior approach, and the patients can tolerate it much easier. Basically, you'll prep the skin, you'll anesthetize the area, you'll put a sterile probe cover on, flex the patient's elbow to 90 degrees, and then in a transverse plane, you'll slide up and down until you get the largest and deepest pocket of fluid, and then your needle will come just to the lateral end of the probe. And this is actually too shallow an angle. It's almost perpendicular. It's almost parallel to the ultrasound beam, going directly towards the fingertips, sliding just inside of this lateral epicondyle. And this is probably the most satisfying arthrocentesis video I have. This is not. This is all one arthrocentesis where you just keep pulling more and more and more and more fluid out of there. It makes me worried whether this person has an arterial bleed in here, but eventually we get this taken out and the patient feels 1,000 times better. Now for the wrist, when you're doing a landmark-based tap, the typical landmark is the dorsum of the wrist, just distal to Lister's tubercle. So if you feel on your own wrist, if you slightly flex and laterally, ulnarly displace that wrist, you'll feel the Lister's tubercle, and there's a divot just distal to Lister's tubercle, which is the space that where the tendons of the extensor compartments have kind of separated to go around Lister's tubercle and gives you a little bit of a gap to insert your needle. And this site works nicely for ultrasound as well. So again, finding that radiocarpal joint and then sticking the needle in there is very helpful. Again, just a little reminder before we talk about tendinopathy about anisotropy. And so this is going back and forth here. You can see this is a short axis view. These are the abductor pollicis longus and the extensor pollicis brevis. And as in a short axis view, as you fan towards the fingertips and towards the elbow, these tendons disappear entirely if you're off by more than 5 degrees from perpendicular. And so making sure you have a perpendicular approach is important to avoid overcalling tendon pathology. Dequervain's tenosynovitis is the tendon is the inflammation of that tendon compartment of the APL and EPB, and you'll see this rim of fluid. Oftentimes you'll see a division between the two tendons, and that division between the two tendons, they should be kissing one another. They should be right up against one another. This is in long axis view. You see fluid on either side here. So for this case of tenosynovitis, you see how there's fluid that's worked its way between these two tendons. That's not normal. And so you could treat this person with rest, NSAIDs, thumb spica splint for several weeks, or you can take 1 cc of triamcinolone or Kenalog in an insulin syringe, 1 cc insulin syringe with a 27 or 30 gauge needle, and just approach laterally here, get yourself into that tendon sheath, not into the tendon itself, obviously, and then inject your steroids, work it through the compartment, and then the patient will have a cure in 90% of the time. You can just continue to watch it to make sure that fluid works. That fluid works all the way around both tendons. Moving on to the lower extremity, this is an ultrasound of the normal hip. Remember that the hip does not go straight up and down. The surgical neck of the hip cants inward. So to get a long axis view of the surgical neck and the femoral head, you want to cant your orientation mark obliquely towards the midline. So your orientation mark ends up pointing almost towards the umbilicus. And so this is a nice normal hip joint here. Fluid, on the other hand, shows up as this black fluid collection here, and the number to keep in mind is 5. Whether it's an adult, whether it's a kid, 5 millimeters is abnormal. This is a 10 millimeter deep fluid pocket, so 5 millimeters, whether you're dealing with a limping toddler and you're worried about toxic synovitis or transient synovitis or septic arthritis, or whether you're worried about someone with non-traumatic hip pain and risk factors for septic joint. This number, that 5 millimeter number, works well for adults as well. Now, arthrocenteses aren't done a lot in our department. Orthopedics, however, does not do them at all, and interventional radiology does them during kind of business hours. So there have been times at nighttime where this has been something that has been able, the ability to do this can expedite someone's care and someone's diagnosis. Again, that orientation mark toward the patient's umbilicus, the hip slightly flexed. Identify this anterior synovial recess as indicated in this cartoon. If you have questions, you can compare to the contralateral hip. A positive study, that anterior synovial recess is 5 millimeters or greater, or if there's a 2 millimeter or greater difference between the two sides. Now, one caveat to this is someone who has chronic rheumatologic disease. You're going to want to take a healthy dose of skepticism in people who have chronic joint disorders. To do the tap, you identify neurovascular structures, you stay lateral to them, you sterilely prep and drape and cover, and you advance a spinal needle under local anesthetic. It is a much easier technique than threading an ultrasound guided line into a dialysis patient. This just shows the challenges of doing this in an adult is that the depths that you're dealing with are much more than in children. So this is 6 centimeters deep, which is as deep as we get with this linear probe. So we just see the very edge of the femoral neck. This is the fluid collection here. This is the overlying iliopsoas muscles, and so we are guiding a spinal needle towards that target through those tissues, and it involves basically hubbing out that spinal needle to get to the fluid collection. For the knees, we don't use ultrasound as frequently. These are very easy to do without ultrasound guidance, but patients are getting larger. That complicates our ultrasound, that complicates our physical exam, so ultrasound can be really helpful to identify fluid collections. Ultrasound has also allowed us to tap small effusions in symptomatic people with immune compromise, where delayed identification of a septic joint can have enormous consequences. So I use 2 different approaches with ultrasound to the knee. If I'm looking to identify the presence of fluid, if I'm looking to diagnose a joint effusion, I'll use a long axis view above the patella. For subtler collections, you can sweep laterally or even medially. You can have the patient contract the quadriceps to shift fluid around, but long axis view above the patella for ID of fluid. For aspiration of fluid, once I've found the fluid, I'll turn short axis above the patella and use an in-plane technique. I'll slide either laterally or medially to get away from the quadriceps tendon and just aim for the deepest pocket. Orientation mark towards the head. What you see down here is the femur. Up here you see skin and soft tissue, and then quadriceps tendon right here. And so this quadriceps tendon comes down till it links in with the patella, just off the image to the right. Oops, there it is. There's patella just coming into the picture. We have two fat pads here. There's the suprapatellar fat pad, this triangular fat pad, and then the prefemoral fat pad. Suprapatellar fat pad, prefemoral fat pad. In between there is a potential space. This is where that black synovial fluid is accumulating. If I'm going to do an arthrocentesis, I'll do a transverse view. Here's distal femur. I'm just coming in from the side here into that deep pocket of fluid. Same thing, coming in from the medial aspect, sliding underneath this quadriceps tendon right into this deep pocket of fluid. Just one thing to point out, the difference between where this fluid is in the knee. Here, this is inside the knee joint, deep to the quadriceps, deep to the patella here. That's very different from prepatellar bursitis, where you have the patella here. This is the patellar tendon here, and then anterior to patella, anterior to the extensor tendons, you get this hypoechoic ballotable area. That's prepatellar bursitis, which is different from joint space effusion. Sliding down to the ankle is really challenging to tap, has a much higher failure rate. Ultrasound guidance makes this a much easier procedure, and just like when I'm trying to find the shoulder joint, and I start with the scapular spine because it's a landmark I can find on anybody. Same thing with the tibia. I can find the shin bone in anybody, regardless of BMI. And so I'll get an ultrasound, put it right on that tibia. I'll know I'm right on the tibia when I have a really bright reflection and kind of this mirror image artifact. And then I'll slide distally. And as I slide down towards the feet, keeping this tibia in plane, eventually the tibia will dive off at the end of the tibia, and then you'll have the talar dome rising up out of the depths. And it's that tibio-talar recess where fluid will accumulate. If I'm going to do a tap, I'll identify where the dorsalis pedis is on ultrasound, and then come medial to that, typically medial to the tibialis anterior tendon, and mark the skin. I'll figure out the angle and the depth, usually about 2 or 3 centimeters, till when my needle should get to fluid, and then I'll tap it. So as I slide down distally here, the tibia falls off here, and then the talus comes up here, and this is fluid in that tibio-talar joint. Again, here's the distal tibia here, talus coming up, here's fluid. In this picture you see dorsalis pedis directly overlying this fluid pocket, so you'd want to slide medially with your probe and then stay medial to your probe when you're doing your tap. Same thing here, you have tibialis anterior here, you want to make sure you slide medial to get to that tibio-talar joint fluid. And then just to throw in the first MTPJ, this is the dorsum of the foot, most common place for gouty flares. Oftentimes our patients are sick to the point where we can't give them steroids because they have chronic renal insufficiency. We can't give them prednisone because they have brittle diabetes. We want to avoid rushing to opiates if we can avoid it, and so this is the dorsum of the first metatarsal coming down to the MTPJ. This is the base of the proximal phalanx of that great toe, and the joint space itself looks like a little cartoon bubble that points toward the patient's head. And you can, as long as there's no overlying cellulitis, you can sneak that little tiny needle into there. You can aspirate out fluid, it's very satisfying to get that fluid out of there, inflammatory fluid. Send that off for your counts. And if you're confident that there's no infection, through that same needle, you can go ahead and inject half a cc of triamcinolone or Kenalog. That's 20 milligrams of triamcinolone plus half a cc of lidocaine 2%, and the patient will have immediate and long-lasting relief. Just going to finish up talking about fractures and then wrap up. The musculoskeletal ultrasound is helpful for identifying fractures, even though I said earlier that air and bone are the enemy of ultrasound, and bone is unultrasoundable. It's true, ultrasound beam does not easily pass through bone, but this bright reflection from the bony cortex allows for detection of small fractures, and you can really identify millimeter of misalignment or a tiny amount of angulation to a fracture, especially after a reduction attempt. And so this is a radial head fracture here that was not seen on X-ray, was only seen because of a joint effusion, and you can see that disruption at the surgical neck of the radial head, and so that disruption of the cortex and the difference of the shadow behind here that draws your attention to that crack in the cortex. Again, here's a distal fibular fracture here with a disruption in the cortex, about a 15-degree angulation. These are 5 millimeter markings, so this is a less than a millimeter displacement. There's a tiny little bit of hemorrhage around it, or hematoma, and then there's this disruption in the normal shadowing behind this bone. This is someone who presented where the team was suspecting a dislocation. And just taking a look here, you can see that this is a sagittal view of the anterior humerus. You can just see this disruption in multiple planes of the proximal humerus. You can see multiple fragments here with the shifting shadows deep to there. So to wrap up, ultrasound is very helpful for distinguishing abscess from cellulitis. It helps to avoid important structures you don't want to damage on incision and drainage, and it helps you to identify necrotizing fasciitis. It's also great for identifying foreign bodies. 4 out of every foreign bodies you'll see, 1 out of 5 you will miss. Make sure you tell your patients. Pay particular attention to shadowing behind these foreign bodies to help you how to identify them, and use Hydra dissection to remove those foreign bodies under ultrasound guidance. With tendon injuries, both ruptures of the big tendons of the legs as well as lacerations to the hand and wrist tendons, it's very helpful to identify that the retracted end of the injured tendon. For tendinopathies, decore veins, tenosynovitis, again remembering anisotropy, but an injection of steroids, and your patient will thank you if you give them rest, ice, compression, elevation, thumb spica, splint, NSAIDs. They will be symptomatic for weeks. So let's treat and resolve decore veins. If you have any question about whether the patient has a joint effusion, use ultrasound. If you're having any challenges getting fluid out, use ultrasound to help you to guide your needle towards the biggest pocket. And then fractures and reduction. It's helpful to identify fractures. It's also very helpful as you're trying to guide your reduction to an anatomic alignment. Before you put a splint on and send the person to X-ray, you can ensure that you have minimized any displacement and reduced any angulation before you put the splint on and get their post-reduction X-ray. All right, thanks for your attention. See you at the hands-on scanning.